All righty. Hi, can everyone hear and see well?
Looks great.
Okay. So yeah, I am going to talk about well, I was asked to talk about some challenging cases and give examples, and um, and I love doing this. I love taking care of patients that need to be evaluated for possible surgery, and I've enjoyed my entire career trying to figure out where seizures come from because it's so rewarding. That simple, but it's also really challenging, and there's a lot of pitfalls, and it's also really humbling. In spite of all the advances, and I'm going to show you some of the sort of at least the best established new tools, or tools not necessarily new, but maybe improvements on them, to try to figure out where seizures come from for targeting with surgery. And it doesn't have to necessarily be removing tissue that's responsible for seizures, because nowadays we have ways to target and treat with stimulation devices and whatnot. But I really just want to talk to you about the chore of finding where seizures come from. And this is what patients have to go through and what we have to explain to patients. And I do this with patients just as I would with medical students or residents, because as you'll see, maybe the technology is really advanced from like a pure physics standpoint or whatnot, but the actual chore, the job we're trying to accomplish, is something anyone can understand. Let's see. So I'm going to talk about tools that we use and they're going to be involved in the examples that I show. And I think everyone's familiar with brain imaging and scans, particularly MRI, which is sort of the best imaging we have. It's just quite remarkable how elegant and exquisite you can depict the brain of a human being based on a scan. I mean, it almost looks like an autopsy, and it's become so good that it's remarkable when we analyze or we evaluate patients with seizures and the MRI is normal. How can that be? And one way it could be is it's molecular and something, it doesn't have that kind of resolution. And most genetic epilepsies by definition are molecular, but all other epilepsies, particularly those that involve some type of either malformation or scar or injury, you would think you could see it on the very high resolution MRIs of today, but not necessarily. Some of it is still microscopic and not detectable by MRI, but it is our mainstay way of looking for substrates or something that we could put our finger on, literally and figuratively, that would be maybe responsible for the seizures. And it really has revolutionized the diagnosis and care of patients with epilepsy. And then functional imaging has been around too, even older than MRI in some ways, or not in some ways, but in fact, is older than MRI, like PET scans and SPECT scans, and I'll talk about those more. They're important because they are measures of function and not structure. So you can have normal structure, and you can have an abnormal PET scan, you can have an abnormal SPECT scan, because they are images of function. And they are actually, they're used for other tools. Well, Ictal-SPECT specifically means for seizures. Ictal just means during a seizure. But SPECT scans are used for all types of diseases, and so are PET scans. But they're like some of their most striking, profound applications in epilepsy. And then, although I'm throwing it under functional imaging, but EEG are really the main tool we have to directly detect and mainly to directly detect and characterize seizures. And that's been around for many decades. That's our oldest tool. It's still our main tool because it is direct. Everything else is indirect. MRI, PET, Ictal-SPECT, doesn't matter. Those are all indirect connections to what's causing the seizure, maybe where the seizures are coming from. And a newish tool, although it's not that new anymore, but it's been around for maybe 30 years is MEG. And one thing about MEG is it's analogous to EEG, and I'll explain later when I go through this a little bit more. But it was always tied with imaging from the very get-go. When it came out in the early 90s, mid 90s, late 90s in particular, it was meant to be used with imaging. So it was in fact called magnetic source imaging and not necessarily MEG. And EEG has finally come around to where, well, if we can do this with MEG, why don't we do it with EEG? And there's some reasons that it had been late to develop as a tool for actually trying to infer what we record with EEG and putting it in three-dimensional space and an imaging space. But it can be done. It's more challenging than MEG, but it's something that's being done increasingly so, but it is definitely not commonplace. But I will show some of the examples of what can be done. So let me first sort of frame the context of why we do and when we do these tests. So when we are trying to decide if a patient's epilepsy may be treatable with surgery, it really is under the guise or presumption that the patient has seizures coming from a spot in the brain. And that already limits you to patients that have one type of epilepsy. There's really two types, those that we call generalized and those that we call focal or partial. And so you have to have focal or partial epilepsy, because generalized epilepsy, there's no one location. It's the whole brain, effectively. So EEG usually can help us detect and determine that. But for everybody else, where the seizures do appear to be arising from part of the brain, it's what used to be called partial epilepsy, but now called focal epilepsy. Those patients in whom medicines do not control their seizures potentially could be candidates for surgery if we could just localize where that spot in the brain is. And this brings up another big assumption. You know, it has to be not only a spot, but it has to be one spot for the most part. You can't really target more than one spot, although that's changed a little bit with surgical procedures that involve just stimulation of the brain. You can target two locations. So those sort of first criteria have to be met. That, okay, the patient, I need to know if the patient has seizures that start in only part of the brain, and that it really be only one part of the brain. And that's sort of that's it. You know, the rest is honing in and developing more precision and determining if that spot is located in an area of the brain that's responsible for other functions that would be interfered with if you had surgery. But our first big problem is determining if a patient has seizures that come from a part of the brain, a single part of the brain. Because if they do, then at least there's potential for the option of surgical treatment. And it is a very big deal, because in patients whose medicines have not worked, in spite of multiple trials, the likelihood that some new trial, another medicine, is going to achieve seizure freedom is pretty low. And it's not zero by any means, but it's probably less than 10%. You know, close to 10%, I would say less, maybe between 5 and 10. So it can make a big difference. And even if only half the patients that you attempt to treat surgically become seizure free, and that is roughly the percentage. You know, you think, oh, that's not that great, half, but you know, that's actually, for every 2 patients you treat, 1 patient becomes seizure free. That's a big difference. Most surgeries don't have anywhere near that effect size. But let me just talk about this graph here, this figure. So when we find patients that have EEG localized seizures and they have an MRI lesion, those 2 tests, you can actually, if they concur and they agree, you can actually go straight to surgery. But for most patients, it's not that simple. We need additional information. In fact, we need a lot more additional information, because the EEG is a very rough estimate of where seizures come from. It's been used, you know, for all these decades, mainly as a detection device, not as a localizing device. You know, And so these other tests are used, and then you can decide, well, is it localized or not? Maybe surgery from there, maybe not surgery at all. Or C, you could say, well, I have a better idea. At least I know where to go looking. And the next step is placing electrodes in the brain. That's called intracranial EEG, and that's a big step. And it's not a step to take unless you have a very good chance of finding out where the seizures come from. And a lot of that depends on these initial tests. Because one, you can't place a lot of electrodes in the brain. And two, it's easy to place electrodes close, but not close enough, and then to be misled and get the wrong answer. So now I'm going to just move ahead. So EEG and MEG, starting with these are EEG is our oldest test, and most EEGs are done as an outpatient. You sit in a room for 30 minutes or 45 minutes, and we record the brain waves, and we're looking for these abnormal discharges we call spikes that you're having even when you're just resting quietly. They're not symptomatic, and but they are diagnostically valuable. And this is the case for most high resolution EEG studies where you have to place lots of electrodes on. They just don't stay on long enough in an accurate way with high fidelity quality of recording, for more than a few hours. And MEG is this big instrument that's in the back of this picture that, is not movable, and you can sit in it for an hour or so, but that's about it. So these are what we call interictal recordings, and they are the first basis of trying to localize seizures. But they're limited because you're not actually recording seizures. You're recording these surrogates. And you'll see in a case later that no matter how accurate you localize these, you may not be able to depend on them pointing to exactly where seizures come from. This is just another way of looking at it. There's another problem with recording EEG and MEG, and that is, one, you can see in this figure, the big spheres out on the perimetry, these are actually detectors for MEG, and you can put hundreds of them. Most instruments today have over 200, and most EEGs, a standard EEG is 21 channels or 19 electrodes. This particular figure shows 74, which is considered high resolution EEG. And like that cap I was wearing before. But even with this high density spatial sampling, you can see that we don't get below the brain very well because we can't. There's tissue in the way. You can also see that the image detectors, these spheres, are pretty far away from the brain. So there's some limits to this. And there's some differences between the two. They both record the result of the electrical disturbances that we're looking for. The seizures are caused by a paroxysmal, sudden synchronization of populations, patches of neurons. And these spikes represent patches. And actually, they're recorded at the scalp. They have to be pretty large, like several square centimeters, in order to generate literally just enough voltage to see at the scalp. But EEG records the electrical potential, which is measured in voltage. And the MEG records the magnetic fields generated by electrical currents. The sources are the same, but what you're measuring are different. And MEG really can't see things that are directed like this. This big patch of cortex in some is sort of directed radially toward the center of the brain. That's what EEG is very good at recording. It records everything, by the way, not just radial sources, but and since the head is like a big ball, it's almost everything is radial. But there are a lot of deep sulci, and they contribute to the sources as well. And when they are more tangential to the surface, then you can detect with an MEG the magnetic fields that are circulating, that are going around a circle around this current. So MEG has some weaknesses because it can't really see these radial sources, but it can see very accurately these tangential sources. And this little figure shows that in MEG, all of this would cancel. The only thing you would see is the edge, so you can get this edge effect with MEG too. So it's a little tricky. These are all well known, and as long as you understand them, you won't make any mistakes in sort of interpreting them. And this is what traditional EEG looks like. And this is how it's interpreted to this day. You look at the tracing on the left, the upper left, and it's just, you know, signal over time. And this is actually an average of a bunch of these spikes that I was talking about. And you sort of have to just sort of guess. And if you're lucky, you might develop a map and say, yeah, they're on the top of the head on the right toward the front. And that's kind of how we've interpreted it, and we still interpret EEG to this day. It's that sort of general and loose. But you can do source localization. Certainly do it with MEG, because that's what it's always been used with. And when you do source localization, you're basically saying, where would the source have to be to generate what I'm measuring at the scalp? And with MEG, it's a little easier. It's a lot easier, actually, because you don't have to worry about the bone and all the tissue between the electrodes or the detectors and the source. Whereas with EEG, the electrical potential, it's affected by all that. As it goes through, as it just sort of, what we call, conducts through the skull and the other tissues before the skull and the spinal fluid, it gets attenuated and distorted. And we get sort of this rough idea on the scalp. But there are lots of ways to deal with this mathematically. There's a lot of assumptions we can make that are valid based on our knowledge of where the seizures should be coming from, that help us overcome some of the difficulties with making this big inference about where the source can be. This is showing the EEG estimate of the source, and notice it's kind of deep and it's pointed radially, no surprise, because of radial orientation. And look at this, really tangential and not so deep. And this is the MEG estimate. The EEG is actually off more than the MEG, but that can be corrected too, and I'll show that later. But this is an advance that's sort of coming along slowly, but taking over. It is very helpful, but remember, these are basically these high-end EEG and MEG recordings that are mainly done not on seizures. This is a much more fancy analysis of the MEG, where you can actually depict it rather than sort of what we depict with these dipoles, where we actually sort of force it and say, where would it have to be in the cortical mantle? And it's quite remarkable. It can be very accurate. And this, to know that this is done completely non-invasively from outside the, outside of the skull, it's a tremendous technological tour de force, and not always easy. Sometimes you cannot do this, but you can see this is one of those discharges I was talking about. This is 1 second. This is how brief these things are. They're just a blip, but they're telltale hallmarks of potentially where seizures come from. And you get this, if you can do source localization, you can get this put on the patient's MRI and have a far better idea of where the source is than sort of trying to just go, well, it's toward the back of the head on the right. So next is PET scans. These are the most established. This is the most established imaging technology besides MRI. PETs measure our depiction. They are tomographic scan. Tomographic just means these slices through the whole brain. They're sort of like a CT. In fact, PETs are based on computed tomography methods. But instead of taking a picture of the structure, you're taking a picture of the brain's metabolism of glucose. It's based on glucose. That's what FDG stands for, fluorodeoxyglucose. And the P stands for positron emitting tomography. And there is something kind of cool and unique about positron emission tomography, and that is the positron emitting isotopes are very special. And they, because the energy that we're trying to detect to create these depictions is based on photons. It's just electrical energy from when there's decay of the radioactive nuclide. But with positrons, when they decay, the positrons travel just barely at all before they collide with an electron, and then they shoot off photons in equal and opposite directions. And this is really cool, because if you have detectors all around the skull, when it detects any photon, it knows another one in equal and opposite direction must be arriving at any time. And when there's a difference in arrival, which almost always is, unless it's perfectly center of the brain, it knows, okay, I know the line between these two photons arrivals, and I know the time difference. So I know exactly where in that line the source was. And that's why positron emitting tomography images are much, much better resolution than standard single photon images. But PETs are hard. You look at this little thing, this little divot, is that real? Is it not real? Turns out in this case, it's very real. And it's the only thing abnormal in this patient. The MRI is perfectly normal. And that is exactly where her seizures come from. And under the microscope, it is very abnormal. But how do you read these things? They're really hard. And in this particular image, the one that's outlined right here, there's a very subtle possible lack of metabolism there. And by the way, we don't know why metabolism is decreased in places where seizures come from. One reason is we said, well, you know, it's just not, I don't know, it's there's a lot of inhibition going on around that. But inhibition takes energy just as much as excitation, right? It's based on synaptic energy, and so that's not a good answer. Mainly it's just not as well functioning. The tissue where seizures come from is not as well functioning, at least not always, and that's why we can detect it. So we find these relative decreases in metabolism, and that's a very questionable. I mean, no one would call that without some help. So nowadays, though, we can digitally map these things onto a patient's MRI, and this MRI too was read as normal, and there's, well, maybe not, maybe that's a little abnormal. You put the PET together, and lo and behold, that is ametabolic or almost ametabolic. And you go one slice back, still there, and you're like, well, maybe that's just, I don't know. You go to the next slice, normal. Go to the next slice in front of it, normal. So that turned out to be also, just like that prior patient, that turned out to be very abnormal in the microscope and where the patient's seizures came from. So pretty cool if you can detect these things and be correct. You know, you can be very overly sensitive and call things that are not truly abnormal. It's easy to do. And you can also just miss things too that are real. So this brings up next is Ictal SPECT. So this is one of those single photon emitting isotopes. This is, but well, really special aspect of this type of scan is it's a picture of the brain during a seizure. You only can acquire it by injecting the isotope during a seizure. So it's very difficult to get, but in some ways it's almost like cheating because it's like taking a snapshot of the brain's blood flow, because this isotope is based on blood flow. It's an isotope that is relatively short acting, you know, you only have like a 4-hour window before the isotope decays. But if you can inject it within, at the earliest point of a seizure, it has this really high affinity to bind to the blood vessels. And so it sticks and it reflects the blood vessels at that moment. And really within like 12 seconds, 10 seconds of injecting it, you know. So it's not perfect because a lot happens in 10 or 12 seconds. But if the seizure has sort of started and stays relatively powerful and strong where it started, it can be, you know, it can basically put me out of a job. So here's an example. So this is a scan. You can see that they're nowhere near the same resolution as a PET scan. They're much blurrier. But this is a scan, and there's like a little bright spot there. And that's ictal, meaning during a seizure. And we also get a scan when they're not having a seizure so we can compare. And you go, yeah, maybe that is brighter. But this is actually a pretty good scan, but still, it's pretty subtle. And you don't want to hang your hat on that necessarily. So someone came up with the bright idea of saying, you know what you should do is subtract. Take the scan when they're not having a seizure, subtract it from the one when they're having a seizure, and whatever's left over is related to the seizure. And then even better, put it on their MRI. And that's what this is. It's called Subtraction Ictal SPECT with co-registrations to MRI. And that is a big improvement. You know, not only did you sort of magnify this or isolate it, and also there's some magnification of the difference because between when the patient's not having a seizure, you remember, it's not functioning as well. So it might actually be relatively decreased in blood flow. So you get benefit of when you subtract it. But these scans can be very noisy and very difficult. This is just a good example, just for purposes of demonstrating it, but they can be almost uninterpretable too. So a new technique to make them better is to take that difference, that subtraction, and say, you know, it's not just a subtraction, but I want to, you know, everybody has differences. If you or I had a scan today and tomorrow, just a resting state scan, they won't be exact the same. There are differences between one scan to the other. Lots of technical differences too. You know, the isotope is a different dose at the time. You can't really, you try to correct for all that. But this is one way to sort of say, okay, well, get a bunch of normals that have had 2 scans, just like the patient had 2 scans. Subtract the normals, you know, their day 1, day 2 scan, and make that your baseline. And then you compare the patient's subtraction statistically to the normals. And that really cleans up. And that's what this is called. It's ISAS, statistical parametric. And look how we just took this scan and converted it to this. So you see why I'm out of a job? If it wasn't so hard to get these scans, I would be out of a job, but that would be okay with me. There's a couple of things that I've hinted at though that are make this difficult, or make this not necessarily accurate. And one is it takes time. It takes several seconds, and that's if you're lucky to be in the room sitting there at the very beginning of a seizure. And there's still time for circulation and binding. So it can be misleading, but it can be incredibly valuable if you can get it. This is just an example. This is actually an example of a patient I just showed up earlier with MEG. This is an Ictal SPECT scan. This is a patient who had surgery before that failed. I mean, it helped the seizures a little bit. His surgery was based on intracranial recordings. It was very well done, but it still had seizures. And lo and behold, now we know where. We knew it would probably be close to where the surgery was, but we didn't know if it was going to be up here, down here, behind it, in front of it. Now we have at least a good idea. And sure enough, too, this just happens to match up really nice with that MEG, in fact, almost the exact same area. But this is ictal, this is seizure, and this is interictal. So it's a nice corroboration that, wow, at least his interictal data is very close to ictal, the seizure related, so non-seizure, seizure related. So anyway, now I'm going to go into showing you some examples of challenging cases where there are very difficult and humbling scenarios, but still worth the challenge. First patient, this is a 35-year-old woman who, at age 19, when she was in the military, she was in the Air Force, she was in Thailand, and I don't know what she was doing, but she fell. It wasn't like she was rappelling. She admitted that it was not while she was doing active duty. She was off duty. And, but she fell through a roof in some Thailand, I don't know what. She fell a long ways, like I forget how many feet. And she hit a pipe going down and she really got hurt bad, in spite of the fact that she's doing quite well now other than her seizures. But at the time she had to have an urgent, they had to actually open up her skull to decompress it. That's how bad it was. And, but she survived and she recovered and she's done really well except for her seizures, and they've never been controlled. And they are kind of complicated. This start with a dizziness, it's kind of vague, and this hand jerking, and drooling, and then her whole body, well, she's still conscious. Pretty interesting. And that's actually kind of a clue that she's still conscious, and the whole body is tugging and tightening sensation and a little bit turning. And then unfortunately frequently progresses to a convulsion. And it happens a lot for convulsions, 1 to 2 times per week. And, a person who's trying to work and have a family, and it is, it's remarkable. So this is an example of those spikes that I was talking about that you can capture, and you can do all this fancy MEG with or EEG with. This is actually just really fancy EEG source localization. When you're relying on spikes or sharp waves, these EEG abnormalities that occur when you're just resting quietly, and they're not your seizures, but they're the hallmarks, you can get burned occasionally. Thankfully, it's not very often, but these are these beautiful spikes. You have them all day long. This is an average of a bunch of them. And this is the actual recording, and this is the computer best effort to say, well, if I have to figure out where the source has to be, this is the best I can do. And it matches really remarkably well. And it's these red things. They sort of represent these dipoles. They're sort of at the bottom of this injury. Look at all this injury. But this is their ictal SPECT in yellow. So it's up, it's above. I didn't really want to have it on this particular image, but anyway, that's the EEG. way down here. And when you actually record directly from her brain with implanted electrodes, and that's what these represent, the blue and the red is where the seizures are. You can see they're up there, and sure enough, they're close to the ictal SPECT. They're not where the spikes are. These are all just different estimates of the spikes of either MEG or EEG. There's both. They're mixed, and they're way down here. So if you had based a surgery on this, you'd been totally wrong. Turned out seizures come from up here. But now I know why, because these right here, this is the seizure up here going, but these are spikes, and they just happen to be going on even while the seizure's going on. They don't even go away in a totally different location. So it's just, I always love to show this when I teach. I like to show it to myself and remind me that you can't assume that spikes are where seizures come from. Most of the time, though, they are. So thankfully, it's a good example. So case 2. This is a really tough case, but very interesting. 25-year-old woman whose seizures began at age 5. She actually did well. She was seizure-free until age 11, so 6 years. And then she had like not a bad head, like a concussion, nothing like the patient I just told you about. You know, something that normally you wouldn't even worry about, but I think it was just a straw that broke this camel's back, and it's got her seizures going again. Or it just converted what was controllable with medicines to something that's not. And these seizures occur mostly, almost exclusively at night, and usually right after she goes to sleep. So, you know, she takes a nap, same thing. And they occur numerous times per night, which is not that, I mean, it's rare, of course, but it's not that rare for patients who have seizures arising in the frontal lobe to have multiple per night. And they're usually brief. They just go back to sleep. You know, it's a bummer, but you know, as long as they don't have them in the daytime, it's not so bad. So she put up with them for a long time, and they just got increasingly frequent. They weren't always 15 to 20 per night, but by the time they got to 15 to 20 per night, she was like, got to do something. I mean, it's really actually hard to sleep and hard to do things the next day. And she has them basically every night now. So what she describes is like when she has them, she awakens first. She goes, I always awaken first. I feel this indescribable sense of fear and panic. And then she feels like her chest is closing in, like it's almost like a panic attack. I mean, it sounds like a panic attack. And then she can't gasp for air. That's also really classic. You know, people feel like they're suffocating. But then, and this is over a matter of seconds, 10, 20 seconds, maybe 15. And then she starts to have all these really complicated movements of her limbs. And they're not shaking or jerking per se. They're just complex movements typical of frontal lobe seizures. And one feature that's sort of striking amongst, I don't know, it's hard to characterize these movements, but she has these, at least toward the end of the seizure, this profound sort of stiffening, extension, and splaying of her legs. And then it ends. And then she just rolls over and says, "Ugh, I'm going to go back to sleep." And she does until it happens again. So we were in a sort of situation where we could try to take advantage of seizures so frequently that we even did high definition EEG, where we place a bunch more electrodes on. Like I said before, that's usually confined to outpatient 1 hour study, but we're like, well, she has those things all night long. We can just do it for several hours. But even so, EEG, even with the high density EEG, was completely negative during her seizures. And this occurs particularly with frontal lobe seizures. If they're in a part of the frontal lobe is large, and there's lots of surfaces that are they're kind of deep, in between the hemispheres, in particular, underneath, above the eyes. It's, we never like say, oh, these just can't be epilepsy because we can't see it on EEG. Particularly with something that looks and smells like frontal lobe seizures, we know that you can just have a negative EEG, and you'll see why when I show her intracranial recordings. But so she's kind of negative. So we have no help. Her MRI, totally normal, no help. Her MEG, totally normal, negative, nothing. PET, even the PET was read as negative and probably could be. We'll look at the PET because we've been, interested in this. So this is her PET registered to her MRI, and it's a soft call. You might go, oh, this little area right here, that's right here, maybe a little bit down compared to the other side. I mean, maybe. And it's good to register to the MRI and make sure there's gray matter there, because it would be unfair to compare gray to white. But so it's suspicious. Maybe that's it. So we did an Ictal-SPECT. Remember, one of the things about Ictal-SPECTs, it's limited to a small subset of patients because you have to be in the room with this isotope. It has to be basically in California, a doctor in the room waiting for you to have a seizure to inject it. And you only have like a 4-hour window because the isotope's decaying, which is a good thing. You don't want isotope around much, long, but it's a short window. But she has very frequent seizures, and all we have to do is get her to go to sleep. And we captured one. And this was a really good Ictal-SPECT. And it's in the at least, I couldn't even have told you what side her seizures came from based on her history and her negative evaluation. But at least I know one, it's in the left, it is left frontal. And you're like, that is a deep area. That's pretty deep. And if she has a seizure there, very could, what I'm trying to say, very easily could be negative on EEG. It's too deep. But this is where you can get burned by SPECT because SPECT is, one, it takes a lot of seizure activity to generate these blood flow changes. And no matter how good we are at injecting, it takes time to get the injection in, to get the flush in, to get at least a few circulatory passes for this stuff to bind. So we could be looking at where seizures spread rather than where they start. And that turns out to be the case in this patient. So the next step in something like this, it's almost like a needle in a haystack. We have a couple of clues. PET says one area, which is totally in a different location than the SPECT. They both could be related. Turns out they are. But we need a lot more precision before we could ever entertain the possibility of surgical treatment. So this is just a little cartoon showing like where we're going to place these depth electrodes. And here they are. This particular one is going sort of to that area on the PET scan. That's in we call the cingulate. This is a little bit behind that. And this is in the insula, which is close to where the SPECT is, but this is closer, a lot closer to where the SPECT was. And this is even further behind in the mesial frontal cortex. And this is the temporal lobe. We needed to do the temporal lobe too because she has that component of panic and fear and whatnot. And we just needed to understand if that was involved or not. So when you look at these recordings, it's quite fascinating, actually. This is the seizure onset right here. Just 2 electrodes, 2 tiny electrodes, just and they're very deep. It's in fact that one. That one right there is this electrode right there. And you look at how low a voltage that is. It's tiny. We would never see that at the scalp. And that's why we don't see anything. All we see is a bunch of movement because the beginning of the seizure, she opens her eyes. Here comes the seizure. She's restless. She's looking around. Some things are starting to change here. But I mean, there's a lot of change actually if you just compare here to here and then on this side of the page. But as you see the seizure evolve, still very focal. And in this area that's right there where that PET abnormality was, or suspected PET abnormality was. But as it spreads, as it grows, you'll start to see these electrodes get involved next. At this point, she's bracing, she's holding on. This is when she's got that complex movement. This is when her legs start to, we call abduction, just sort of point outwards and rocking, very sort of abnormal movements. And also there's a involvement of the insula right here too. But this now, in fact, the cingulate area has actually kind of started to stop, but this takes the ball and runs with it and becomes very strong, but still not something you can detect at the scalp. It's still deep, it's very deep. And lo and behold, this is right where the SPECT would be hot, where that's really strong. And that's what the SPECT detected. It detected this. This was just too small for the SPECT, or basically by the time we got the tracer in, it had kind of died down. So you see how you can kind of get burned by SPECT. So it's disheartening to see that and quite humbling. But I think now we at least understand and we have to appreciate that possibility. And this is interesting too, because this kind of correlates with her symptoms as well. And I'm going to summarize some of that coming up here. So this is when the seizure just stops back here. And basically where it stops is a little bit further back. It's back here. So it started here, spread out here, and then it goes to here. And then it's over with. So we learned a few things just by the recordings, but you can also stimulate those same recording electrodes to learn something. So when we stimulated out here toward where the SPECT was abnormal, that's her first symptom. Like, oh, that's my first real strong symptom, is like I got the air knocked out of me. Remember, I can't catch my breath. And that's kind of fits with where that really strong involvement of this area where the SPECT was positive. When you stimulate where the seizures actually started from, which is right here, you can cause a seizure really easily, but you don't cause any symptoms. She's asymptomatic, and no symptoms here either. It's only when it spreads to this area that she gets symptoms. And as the seizure ends, lo and behold, it's in this electrode that's further back. And that's when her legs are doing that. And lo and behold, that is very close to the leg region of the brain. So it kind of makes sense. So we sort of put it all together, and the question was, we still didn't have, we'd sort of figured out with the depth electrodes, at least some idea of what's going on where, but we don't have precision to guide a resection. So we placed electrodes over the seizure onset. This is showing the old depth electrodes. This is where we had the seizure onset in the depth electrodes, but we needed to know, what patch of cortex is responsible. We also covered it outside laterally toward where the SPECT was abnormal. And so these are the recordings from these electrodes, these many electrodes and I'm just showing the ones that are over that patch of cortex where the seizure started with the depth electrodes. Very difficult. But here you can see it is a patch of cortex. It's not just one electrode. And that's why we had to do this. We needed to know what is the extent of the patch of tissue that's responsible for the seizures. And this kind of allowed us to sort of figure out, okay, here's it, and you can see it. And this is just that interhemispheric fissure area. So basically we had sort of said, it's really hard. We didn't have electrodes in front. Those very initial changes were right up in here. So we like, well, what if it's up in the front? You could argue for a resection. You could just say, you know what, just do a big resection. Offers her the best chance of being seizure free. Or you could just say, we're going to be strict. This is her left hemisphere. We have to be careful. Let's just follow. These are all the electrodes that are involved in that seizure. This shows kind of a summation, but it's where it started and then spreads. And we said, okay, we'll go a little bit further anterior since we didn't have electrodes here. And she had her surgery and she had no seizures for the next couple of months. And she had them every night, 20 to 50. So you're like, that's great, right? But this is a common problem with, are you just getting the tip of the iceberg? Or are you getting all of it? And, argues for like, well, maybe you need to do bigger resections because frequently we have to come back and extend the resection. And lo and behold, we have to do that in her case because her seizures came back slowly, but gradually, a little bit different. Remember, this was never symptomatic. It's where they started, but so anyway, we took her back to surgery. Oh, I thought I had a picture, but I don't. And just extended it to the way we had planned on doing it, a big resection like this. And that was about a month ago, and she has not had any seizures since. And thankfully, but it's early. But maybe we should have done that in the first place. So, even though we did all of that work, all that fancy work, and we did it by the book, it's still, we had to go back and do additional surgery. Again, very humbling, very challenging. But I think she's going to do well now. But you still don't know about these other areas that were involved in the seizure later. Could they, by themselves, generate seizures sometime in the future? They always started after this area started. Our hope is that they're just propagation. It tells you how hard this is. Even when you find the spot and you're right on it, you've done everything you could and you did it right, and you could still not be successful. Okay, the final case, and I promise it won't be long, but it's, give me page, okay. This is a 38-year-old mother of 2 children, so she has somehow functioned in spite of her seizures, and in spite of 2 to 3 per week of these pretty significant disabling seizures. She's had them since she was 11 years old. They used to be only nocturnal and relatively infrequent, but gradually over the years became daytime seizures, developed partial onset seizures that would frequently turn into convulsions, not always. Yeah, and she really, again, did well for 5 years, but only 5 years. And she's tried numerous medicines since. So when you look at her scalp EEG, our first most important test, it does say, yeah, I think her seizures arise from the right hemisphere, but I can't say. They're very complicated. It looks like they could be the front or they could be the temporal lobe. Let's pull out all of our fancy tests. First of all, our MRI, it's negative. That's always hard. We need some clue. Or PET, completely normal. So even PETs can be normal. So we did an MEG though. She has these abnormal discharges, like they're little rhythmic, fast discharges, and they're on the EEG. It's like a big area. You're like, well, I don't know. That's the front. This is the temporal lobe. But the MEG localizes them pretty nicely to the temporal lobe. But the temporal lobe is also big. There's a deep in the temporal lobe. There's out toward the surface. There's the bottom of the temporal lobe. There's the front of the temporal lobe. There's the back of the temporal lobe. This is toward the back and out toward the surface. MEG really can't, nor can EEG really detect sources that are that deep, but very strongly suggestive of lateral out here toward the surface and back. And that's a pretty uncommon area. But remember, this is just interictal. This is her seizure on scalp EEG with some additional electrodes. And I'll just tell you, the top half is the left, bottom half is the right. And if you look at this, you're like, whoa. And this is how we read EEGs to this day and try to determine where patients' seizures come from. You could say in the beginning, it looks more right. And then here, it's hard to say. It looks all over the place. But it really is still right. It's just a little bit confusing because of the way that EEG is very hard to, there's ways to make this a little bit cleaner and easier to read. But just for this discussion's sake, it's challenging. And these waves are the best sort of resolved. And then you have these and she's still having a seizure. The seizure goes on. And you have these sort of waves here that are later. So you can do source localization on the scalp EEG, but it's tough. Like, what do you do? Maybe these very beginning waves. How about these waves here? How about these? The first waves are out here that look just like the MEG. I'm like, oh, that's great. They're lateral and they're back here, posterior temporal. Interesting. But I will say her seizures, if you look at this next set of waves, they look much more frontal. And that's within less, a second or a little bit more than a second. And later on, they look even more frontal during the seizure. So it is really, this just shows you like scalp EEG is hard, even when you're doing fancy stuff to localize it. So this is her, so where exactly are these seizures coming from? And this is her intracranial EEG. This is lots of electrodes placed over the frontal and temporal lobes, and then even within the temporal lobe. And it's very complicated. You got a pattern here, or where did it even start? Maybe let's say here, but that's not the sustained pattern. You have these big things coming, got all this going on. So it's tough. So we have some pretty fancy ways to now figure out how to interpret those things a little better. And this is a little easier for all of us, you, me included. So these are all the electrodes on the surface. These are the depth electrodes, and we're just going to walk this through. I'm just going to carry you through this. We're going to run into that first batch of badness right there, electrical badness, I should say. And it's, boom, it's right where we thought it was, right where those MEG and the scalp EEG, it's like, it's back of the temporal lobe and it's out here laterally, because this is the deep part of the temporal lobe and it's pretty quiet. So, okay, so that's like, all right, that kind of fits with what we thought. Look how nice. And as we get closer to the seizure, this is what's the very first thing we see in the seizure. We do see some of that lateral stuff. The very first thing we see is here. And not just that, when we go through that, we get that big burst too. That's within less than a half a second, out more toward the surface and toward the back. Then as the seizure goes, and I'm just going to play it at this point, notice what area keeps going. This area keeps going. This area will light up intermittently, but also the frontal lobe. And you can see why the scalp EEG would be just watch how these waves of frontal, they go. But the place that's going the whole time is this deep area, which we can't even see with scalp EEG or with MEG. And yet but we can sure see all of this, and that's what we're seeing, and we're seeing all this lateral stuff. So you can see why this, this one was really sort of dispiriting when it comes to like wanting and desiring these non-invasive tests to predict what we're going to find when we place electrodes. We'd love not to place these electrodes to try to find where seizures come from for lots of reasons. They're expensive. They have some risks. Every time you place an electrode, there's some risk you could cause a hemorrhage. You can often place them in the wrong places. You can be misled. At least with the scalp EEG, you're seeing at least the whole surface of the brain. You're not seeing these deep things. So it's tough. But the good news in this particular patient was, and I wouldn't have predicted this, but we said, you know what, let's just focus on the deep structures in temporal lobe and also not ignore this because it's safe. Let's just do a very unusual resection where we take both the surface part of the temporal lobe, but all of the deep part of the temporal lobe. And we're not going to touch any of this because as far as we can tell, that's all propagation. I had no expectations. I thought, oh, this is, who knows? And she's done great. She's getting her driver's license. She's a year out, seizure free. Just, it's truly, again, I couldn't have predicted where her seizures come from. And then I couldn't even predict her outcome when we figured it out. But that shows you how challenging this task is. But it's also quite rewarding. As much as it is disappointing, it's, of course, very rewarding when you have patients that do well like her. Not everybody does. As I told you, about half the patients, they may do much better, but only about half become seizure free. And I always say, it is very challenging to find out. You have to make all these inferences and assumptions with these non-invasive tests, but they're all we have. And the better we can do, the better we have at localizing. Because ultimately, even if we have to place intracranial electrodes, we need to know where to place them. Then they can provide the precision we may not be able to obtain with non-invasive tests. But without non-invasive tests, we don't even know where to look. And I showed you a case that even when you find exactly where the seizures come from, you may not achieve the goal of seizure freedom. Lots of the time it's because you didn't take enough tissue. We're always struggling with when we only want to take only what's necessary to stop the seizures and not anymore because you don't want to cause any harm. And yet very frequently you might have just taken out the tip of the iceberg and you may have to come back and you may have to reevaluate where they come from. It may not just be around it, it may be on one corner or one, so again, non-invasive tests like that first example of the Ictal SPECT can be very helpful. And redo surgeries, thankfully, can be very effective. So I always tell patients, if it doesn't go as way, believe it or not, as much as we hate to think about a second surgery, it's not out of the realm of possibility. And not only that, we often actually do, meet with success. So that was a long talk, but I wanted to give you a real idea of what our patients have to go through and what the doctors are trying to figure out, the people doing all these tests are trying to figure out. When we ask patients to go through these things, I think this gives you, I hope, a glimpse at, what it's all about, why we do it. And I think you can understand it as well as anybody else. To me, it's very visual and quite rewarding, but also very humbling. We have a lot to learn still. And I'll stop there. If you have any questions, I'm happy to answer them. This is one of my students. Oh, I can't hear you, Rob. I hear you. See your.
Oh, okay. Are you with me now?
I am, yes.
Okay. So I have an RNS. I actually have one on each side.
Yes, yes.
My question is, which of these, they're both the newer ones, so they can do MRIs.
Yeah, great.
Which other tests can still be done?
Yeah, no, that's great. The wonderful thing about RNS is you get these long-term recordings that you just cannot get when you do a week's worth of recording. And we can, I didn't bring up that pitfall, we can capture seizures in that 1 week, but not only, and one of the reasons patient might fail the surgery is that they have seizures that come from another place that we didn't see.
Right.
Or we can make the assumption conversely, and this is kind of a good thing. We can sort of say, you know what, we see evidence of seizures at least coming from both sides, maybe like in your case, and we can't do surgery on both sides, so we'll do RNS. But when we captured those seizures, it was a pretty unnatural environment. We did it in a 1 week where we ripped off the medications, and the patient may have seizures they don't ordinarily have from the other side. So you might discover with long-term recordings that, wow, these seizures, at least when I'm on medication or with the device in, turns out almost all of my seizures, or all of them, come from one side. So anyway, that's my little preface about long-term recordings about RNS that can be very beneficial. But as far as the tests, to answer your question, because we do want to reevaluate patients that have RNS, and this is an important question. It comes up maybe even more so with VNS, because VNS fails a lot more, or it's not failing, but it's not nearly as successful as RNS. So patients do want to be evaluated for surgery after maybe a VNS has been implanted. And so we're limited. The MRI is a little bit limited. It is with VNS just as it is with RNS. You can do an MRI. You can't do some of the fancier high resolution MRIs. Not yet. I anticipate you can, that we will get approval. We just did our first MRI on a patient with RNS. So I've been waiting to do this for some time. And the scan was actually pretty good, even though it was not a high field magnet. It was fine. It was actually fine for the purposes I was interested in. But one thing that I kind of expected, but I didn't know until we saw it, was that there's still a pretty big artifact from the canister itself. And it, it's small. It's only like, a third of an, not even, it's a quarter of an inch thick. It's, it's about that big. But that, any brain underneath that, right underneath that, is going to be, you won't be able to see very well because of the artifact. Okay. That's not usually where the target is anyway. That's in fact almost always away from the part of the brain where the seizures come from. So for example, in my patient, her electrodes are toward the frontal lobe, and this is back here over the parietal lobe. So I could see very well where the electrodes were from the RNS, and I could see the tissue that had been previously resected. She had a prior low-grade tumor, and that's why we had to do MRIs. And we sort of anxiously waited. We need to follow up. We need to follow these tumors every couple of years. So it was nice to be able to do the MRI, a good quality MRI, not the best, but a good one. And it was certainly interpretable. All the other tests, well, I shouldn't say all the, you can do EEG and EEG source imaging for sure. You can do PET scans and you can do SPECT scans, no problem. SPECT scans are a little bit affected by the again, the canister, because the photons that are coming from the source in the brain, the isotope that's decaying, they hit that canister and they don't go any further. So there's going to be, what we'll probably have to do is just know where that canister is and do what's a correction for that. So it will affect the SPECT scan, at least in that area. But again, since we know that's where the device is, we can do correction. And also that's not usually where the seizures come from. You could still do an Ictal SPECT scan. You just have to manage that RNS device. And you can definitely do PET scans. But again, there's going to be a little bit of an error too from the PET scan, but a little bit easier to correct for with the device. We would just basically have to correct for the fact that, photons are hitting that, they're colliding there. Not very many are going to get through the device. What other tests I'm trying to think of that way? I hadn't even really thought about that too much. But I am thankful now that you can get MRIs, and I've certainly done Ictal SPECTs in patients with RNS, so it can be done.
Great. Yeah. Thank you very much.
Yeah, you're welcome. Well, if there's no other questions, I'm going to go back to the hospital. But I hope you enjoyed it. I love talking about this, and it doesn't matter whether you're, one of my colleagues or a student or for a nurse. I would give you the same talk.
Excuse me, Dr. Knowlton.
Yes.
Hi. Please forgive my amateur question.
No problem. Don't worry.
I was in an epilepsy monitoring unit for 5 days.
Yes.
During that time, I had multiple olfactory sensory seizures.
Yes.
Where I smelled smoke.
Yes.
What kind of test can get that deep?
Yeah, good question. Like that last case I showed, I think it was the last one, that was deep in the middle part of the frontal lobe. And we couldn't see anything until we placed electrodes. I would say the olfactory cortex is possibly even harder in some ways, because it's not just toward the midline deep like my patient's was, which was toward the midline deep, but at least hers was, maybe closer to the top of the head. The olfactory cortex is even further, further below and even further from the front. And it's close to the midline as well. So it might be one of the harder places to see. You possibly could see it with an ictal SPECT if it's a really strong seizure. And in fact, that's probably what we would do before we went and tried to implant electrodes. Although I will say the good thing about your symptom is that it's so specific. It's not, it's so specific that we at least know where to look. And although I will say the brain areas that process smell, they can be a little tricky too. The olfactory fibers are implanted in the nasal mucosa, and they go straight upward into the brain. I mean, literally straight upward into the brain through the cribriform plate, which is just bone with little gaps to allow basically these are actual neurons that go, the little detectors, in the mucosa, but they go straight into they are part of a neuron which sits right above that bone. We call it orbital frontal. It's right above the orbits. And then that's just one synapse. And then they go back into a much deeper part of the brain called the piriform cortex, which is back even a little bit further and more, almost impossible to reach, which is kind of in between the frontal and the temporal, the base of the frontal lobe and the base of the frontal lobe and the deep part of the temporal lobe. And then from the piriform cortex, they go into the deep temporal lobe. So all three of those areas would have to be, potential sites for where your seizures come from. You couldn't just assume it's the olfactory cortex right above the nose. It could be, and that's called orbital frontal, but it could be the piriform cortex, which is like the very most posterior orbital frontal cortex, but a little bit different. Or it could be the mesial temporal region. So an ictal SPECT might be the way to go. We might get lucky if the seizure just involves enough tissue to generate those blood flow changes. And it could maybe answer that question, like which of the three areas. It might not, but even if it just showed, activation in any of those areas or all three of them, at least you'd know, okay, when she says she's having a seizure, we got it. We know she's right, and we have a visualization of what at least what parts of the brain are involved. And then to get more precision, you'd probably want to place electrodes either on the surface of the brain, or in this case, probably more likely depth electrodes targeting those three regions. Or if the ictal SPECT just was really strong in one region, you may not even have to do that.
I also get speech interruptions, so it could be that they're related in the same area.
Yeah, and you know what? It's very common just for you, Elizabeth, that olfactory or that smell component, those seizures, you could involve from the very beginning that deep temporal lobe or the piriform cortex. Mm-hmm. And when they spread, and they don't have to spread a lot, it can knock out language. Mm-hmm. And that's not uncommon. If it's on the left side, there's a very good chance it's going to affect language. Yours would be totally, it would be totally doable. I think it would just be, we wouldn't want to assume that it's the orbital frontal cortex. We would, if the MRI is normal, and we would want to make sure that it's which of those three areas it is, and also just make sure that it's not involving more of the temporal lobe than we think. But it could be done.
All right. I see other questions in the chat. You might want to check.
Oh, I didn't see the chat. Let me check. I'm so glad you said that. Let me stop sharing for a second, and then I'll leave that up. Where's my chat? Thank you. Okay. Okay, Christopher, I'll get back to Christopher. Well, his private message. Okay, so I see Rob's and then with the RNS and Christopher. Let's see, Elizabeth, that's you. You're all. Oh. And with surgery and 2 MEGs at UCSF. Oh, I see. So I see. Can you see Liz Anderson's question? So after 30 years, wow. Gosh. Let me see if I can answer that. You know what, so Liz's question is her son who said, you know, they just have not localized his seizures after two surgery workups, or at least multiple surgery workups, I apologize, and MEG times 2 at UCSF. So I would imagine too that the MRI is negative and the PET is probably negative too.
Yes, it is.
Oh, great. Oh, hi.
Hi.
So tell me, what are the seizures like? What does he do? What was the very first thing he does, if you can describe it, or he can describe it?
He emits a loud noise. Most of his seizures are nocturnal.
Okay.
And that alerts us to the onset.
Yeah.
And if he has one during the daytime, there's kind of a loss of affect.
Yeah.
And then he begins to kind of slump or fall to the left.
Okay.
But as the seizure advances, he just becomes stiff. He doesn't shake, but more of a splayed leg look. Yes. And his hands are clenched and kind of pulled in towards his midline.
Yeah. No, that's really good. So that, and the other thing that's good about that description is that it sounds like it's many seconds. It's not just 10 or 20 seconds. It sounds like maybe up to a minute in duration.
I would say so, yes. Mm-hmm.
Yeah. So that's a case where it's most likely like the young woman, the 25-year-old patient that where we had to put depth electrodes in and then follow up with the array of electrodes in the frontal lobe. But I would strongly suspect that your son's epilepsy is also like hers, frontal lobe, because it is the most difficult. It's not the only place by any means, but it's the one location where the EEG is very, very limited in detecting where the seizures come from. And if the MRI is negative, we're really up a creek. And the reason the EEG is so limited is because usually there's a fair amount of muscle and movement with frontal lobe seizures from the very early parts. So that artifact really obliterates what we can see. But even when that's not the case, like, my patient was similar to your son. She didn't have a lot going on in the very beginning. It definitely got, there was a lot of stiffening like you described and the splaying of the legs. But in the very beginning, she's just restless. She's scared. There's muscle artifact, but it's not, it doesn't preclude seeing something on the scalp EEG. We just don't see it because it's deep. And hers was deep in the inner hemispheric fissure. There's so many pockets of deep gray matter in the frontal lobe that it's, I would say, more common than, I don't know, maybe 50-50, but at least 50% of patients with frontal lobe epilepsy, you may not see the EEG, at least not at the beginning. and you may not see it at all. And that's probably our biggest challenge. And it can be that way with the parietal lobe as well, but it's more common in the frontal lobe.
So the MEG would not pick up anything there either?
I'm sorry, what would?
The MEG would not
The MEG
pick
would
up
not,
anything?
no. And sometimes the MEG can pick up opercular frontal areas that the EEG can't. But I'm a big MEG person, and I have to say, if you can't see it with EEG, it's probably, I mean, it's rare, it's unlikely you're going to see it with MEG. There's exceptions to that, but and that exception is this opercular area because it goes straight in and it allows you to have that tangential. But if you don't have that, it's going to be very hard to see it on the MEG. And just because the MEG is negative doesn't dissuade me from figuring out where the seizures are coming from. I mean, it just tells me, well, one, they're either just not, they're not involving enough cortex, the spikes, and that's all we're measuring with MEG is spikes, and the spikes just may be small, and you just can't see them on EEG or MEG when it's a small amount of cortex. And if it's deep, then you're definitely you don't have a chance. So it's okay to have a negative MEG, and just like the patient I showed, hers was completely negative. Even though she's having spikes all the time when she's just, but they're deep and they're small. You just don't see them. So the answer, at least in 2020, would be two strategies to find these seizures. Increasingly popular is to do depth electrodes, regardless of any of the imaging. They would just say, well, we'll go based on his semiology, which is basically what he does during the seizures. And people that are very expert at sort of deciphering what the patient does from the very beginning of the seizure and as it progresses, they can make hypotheses. Maybe 3 of them, in fact. That's the best epilepsy specialists that do these depth electrodes do that. They'll say, you know what, I think there is 3 possible locations that would have to explain his behavior during the seizures. And they would place depth electrodes in all 3 of those, or to sample those 3 possibilities. And usually that entails, maybe as many as 12 or 13, 14 electrodes in each hemisphere in the frontal lobe. And since they're depth electrodes, and if they're placed sort of like from outside to inside, you can imagine, you basically are sampling most of the frontal lobe. There's still distances between the electrodes, and there's still problems with that method. But and that's why you have to have pretty good hypotheses, or you shouldn't do it. And that's what the experts would say. These people that are really good at placing depth electrodes based on the semiology, and that's become increasingly popular in the United States. It's been popular for forever in France and some other places, but it's now becoming much more popular to do what's called stereo EEG, like true stereo EEG, where you place a fair number of electrodes into the depth of the cortex, so you can get all these deep areas, and it's particularly valuable in frontal lobe epilepsies. But you do have to have a pretty good idea where to place them, and that's where maybe if you were at a place that can do Ictal-SPECT, and it's hard to do Ictal-SPECT, a lot of places don't do it because it's so hard to do. It takes sitting in that room hours at a time with a tech. Oftentimes the patient doesn't have seizure, the isotope is wasted.
Right.
So it's just resource intense. So many places don't do it. It's still, even at UCSF, it is a lot of twisting of arms to get Ictal-SPECT injections done. But if it were available and it could be done, most patients most patients with frontal lobe epilepsy, fortuitous for Ictal-SPECT, they're frequent, every night they have them. So if you can just get them to sleep in the morning when we have the isotope available, usually you can capture it. And if you can capture it, that's where it could be, it's like really the only test we have left, non-invasive test we have short of, that we have basically to help localize his seizures. He is the sort of the perfect example of the needle in the haystack.
Yes,
Um,
exactly.
And that's where
Yes.
an Ictal SPECT can be, it can be a game changer. And that's what I would do first, because it's non-invasive. And if it were positive, it may not get them out of depth electrodes, but at least we'd know where to place depth electrodes.
He has had depth electrodes,
I
but
see.
they, I believe, focused more in the temporal lobe area and
Yeah.
kind of missed where they needed to be. And this was before stereo electrodes.
I believe it. And that's very common too. But before stereo EEG was more widely adopted, and that's only been the past 5 years, I'd say 6 years.
Yeah.
7 years.
Right.
So he probably. Are seizures always the same, roughly the same still?
Yes, they are.
Yeah. And see, that's the good thing.
yeah.
That's what gives me hope. That's the very first thing I want to hear from the patient or their family members is like, as long as they're the same, we have a chance. They're coming from one spot and they've always come from that one spot, and we just have to find it. And I think stereo EEG would be the way to do it. But I would like, it would, it's hard to do a SPECT. You have to come back in again. But, I think most physicians here and places that have SPECT, like Mayo Clinic, and they would all say, let's do SPECT first. And because it's non-invasive and it may help us. And if it doesn't, and if it does, great. And if it doesn't, that's okay too. We'll just go with stereo after that.
Well, he's had 4 workups in EMUs, and he's not very good at performing with seizures when he's there.
Are you kidding? Oh, yeah. So that makes the Ictal SPECT even harder. If
Yes. 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 At UCLA, he went 12 days before he had a seizure.
Oh my gosh. Yeah. That is, yeah. So that's why I hate. That's one thing I hate about Ictal SPECT. It's so limited to those patients who have just. Well, the one thing I would at least hope for is that if he, said, look, I'd like to try this one last time or one more time, it would probably be with stereo EEG. And and the good thing is all the data you have from the prior EMU, that's all valuable, because looking at the video is what's going to help devise the stereo EEG hypotheses.
I understand. Thank you for your answer. I appreciate it.
Yeah. All right. Well, I better get going this time because I'm getting called to the floor. But I enjoyed talking about this, and I enjoyed your questions.
Thank you.
Thank you. Take care.
Bye-bye.
Bye,
Thank you so much.
you're welcome. Bye.
Bye.
Thank you.
You're welcome.